Good afternoon, everyone. I would like to go ahead and get started. Welcome all of you to the Health Outcomes Seminar. As all of you know, this seminar series is sponsored by the Center for Pharmacoepidemiology and Economic Research and the CCTS REACH program. Today is actually a pleasure to introduce one of my former classmates, who's a former alumni of UIC, Dr. Joyce Yu. She's going to be talking to us about cost-effective clinical translation of warfarin pharmacogenomics. She came in to attend the ACCP meeting in San Francisco and was very kind to fly over to Chicago and share some of her recent research with us. She's currently an associate professor at the School of Pharmacy at the Chinese University of Hong Kong. Joyce earned her pharmacy degree here at UIC, followed by a residency at the University of Michigan, and then joined the faculty of the Chinese University in Hong Kong back in 1999. The focus of Dr. Yu's research is pharmacoeconomics and health technology assessment, specialized in decision analytic modeling using decision tree and Markov models. Her recent work, however, has focused on the study of infections caused by multi-drug resistant bacteria and emerging viruses, and also on all anticoagulant therapy, specifically in the Chinese population, and also roles and cost effectiveness of personalized medicine using pharmacogenetic testing, which she'll talk to us about today. Please help me welcome Dr. Yu.
Thank you, Edith, for your kind introduction, and it's great to come back to the College of Pharmacy at UIC after 20 plus years. I was in the class of 1999. Like this, I don't remember there's such a room at that time. So why don't we get started, because I know that we have a tight schedule. I'm going to talk about how to use pharmacogenomics of warfarin in a cost-effective way, because I truly believe it's going to be cost-effective in some way. Now, this is a picture of the university I'm working now, the Chinese University in Hong Kong. It is the university with the biggest campus in Hong Kong. Hong Kong is such a tiny city that we have about 8 universities, and our campus is the largest one. And they have uphills, downhills, and lots of nice scenery. So please come by to visit. And I have 3 items to discuss today: warfarin pharmacogenetic in Chinese patients, and the different care model in anticoagulation therapy, and pharmacogenetic guided management of anticoagulation care. So let's start with the Chinese people first. Now, it is kind of well known that for many years, compared to Caucasian patients, Chinese require almost 50% less of warfarin requirement, and they're much more vulnerable to bleeding complications. And this is a study that we conducted back in 2000, I believe, in 4. Published in 2004, but then it was done a little bit early on that. We look at about 491 patients, totally contributing 451 patient year, and observe them retrospectively, doing some retrospective data observation work, and see how much time they spend in therapeutic INR, so-called the time in therapeutic range, and also when they have an event, either a major bleeding event or an ischemic event, what is the INR at the time of the event. Now, interesting enough, the physician in Hong Kong or the clinician in Hong Kong, they're very cautious. About 50% of the patients all line up in this middle bar. They spend 50% of their time in the range of 2 to 2.4. They hardly go over to 2.5. And 40-something% of them are actually less than 2. So these first two bars add up to be over 40%. And only about less than 10% of patients will have their time spent in the INR range beyond 2.5. So reflect that the physician is very cautious about how anticoagulated their patients are. There's a good reason. You can see that this is a chart to line out the INR measure at the time of an event from all those patients. When there's a major event of bleeding, the triangle is the representing the bleeding event, and the square representing the embolic event. Can we mute? Is somebody calling in? Can you mute your mic? I don't want to share.
Okay. Students from, if you're calling in, please. The noise is disruptive, so if you could keep it down, please.
This is me. No,
that's
mute.
you.
This is me. So I think
But you know what? Let's just mute them so they can hear us.
I think they hear us. Thank you. Now, if you can see, this is a very sharp U-turn, like a hairpin turn. You can see that majority of the event happened in a very narrow INR range, just around 2. So once you go slightly beyond 2.4, and we can see a certain like shoot up of the event rate. And then if you have an INR going down beyond 1.8, you can also see higher event rate of the thromboembolic event. So from this chart, we can see that the range that seems to be the safest one to use with the lowest incident of event per 100 patient year is between about 1.8 to 2.4. Thank you. This is all INR. This is all patient indicator for INR between 2 to 3. So that study shows us how sensitive the Chinese patients are. And then later on, we collaborated with the University of Washington, with David Winstra and Alan Ratty, and that is the time in about 2005. And then just, I think right before that, 2004, they have a paper published in the New England Journal of Medicine. So in addition to the CYP2C1, which has been known for a long time to affect the metabolism of warfarin, the UIC was identified recently at around that time of the year and published it in Nature, and then many researchers at that time was just looking into how does that affect different ethnic group, and we contribute some Chinese patients, entirely like Chinese patients from Hong Kong, in our collaboration and look into what is the distribution of the CYP2C9 polymorphism and the WICOR in the Hong Kong population, see how that affected the dosing requirement. And at that time, we already find out that a lot of the WICOR SNP are strongly tied, linked to each other. So they are grouping them into different haplotypes. The haplotype 1 and haplotype 2 are considered as the low dose and requirement. So they call it the clan A. Other haplotype 7, 8, and 9 are considered as the high dose requirement. That is the clan B. So when we see that the Chinese patient group that we have in Hong Kong, which is about 60-something patients that we collected at that time with the blood and the dosage requirement, we can see that if somebody is homogeneous of the haplotype 1 or haplotype 2, you can see that their daily dosage requirement is relatively low. It's only 2.93, versus if they are heterozygous of low dose and high dose haplotype, they will be in the middle level of dosage requirement around 4.9, almost 5 milligrams per day. But if they are homozygous of the high dose haplotype with the WICOR, they will require much high dose. But then you can see the incidence of the haplotype 7 is quite low, either as a heterogeneous or homogeneous way. The predominant haplotype in Chinese patients is the low dose haplotype. And on top of that, the CYP2C9 incidents are relatively low in the Chinese patient. We only have 4 patients out of the entire 60-something that carry as LI3, and not as and presented as a heterogeneous type with a wild type LI1. And those type of patients, if they carry a CYP2C9 LI3, their requirement would even further drop, even if they are in the haplotype 1. But together with their haplotype 1, 2 effects are all asking for lower dose. So you can see that these 4 patients have a dosage requirement of only 1.9. So that really explains why the Chinese patient, even with a low incidence of CYP2C9 polymorphism previously, still requiring such a low dose, because majority of Chinese patients carry the low dose haplotype of the WICOR C1.
Good to you. Hello.
Yes.
Just to clarify, this was just for the studies published, it was just a little bit after separation from the British rule with Hong Kong. So when you say Chinese, could it have included more mixed race Chinese, or was there something?
We are purely Chinese majority. We don't have that many mixed. Unlike Macau, I know Macau, they will have a lot of cross marriage between Portugal and Chinese, but in Chinese, we have 7 million people. And then like 99.9% of them come from the Canton province originally. So they're all like Chinese without other mix, yes. Now, jumping a little bit ahead of time, we're able to obtain a grant and try to come up with our own warfarin dosing algorithm, including the genotype of the patient, clinical background, and as well as some diet or some of the diet habit of the patient. And we came up with this equation. We include many different factors, and later on by the regression model and the help of a biostatistician. So really, don't test me on biostatistics. And my beloved biostatistician come up with this table 3 for me. That's all I need. I needed how to show individual, like independent variable, how it have the effect size on the stable warfarin dose requirement of our patient. So we can see age, we call genotype, we call C1 genotype seems to be like the biggest effect size on it, and then the next one and then added to it with age that will increase up to 55% of the effect size, and then together with CYP2C9 that will add another 5% because we don't have that many CYP2C9 polymorphism, and then weight. And one extra thing is that we also ask the patient about their vitamin K intake within the last 7 days at the time we collect their blood and obtain the stable dose. We give them a table of all the Chinese diet that have high vitamin K in content and ask them how many servings they received in the past 7 days and collect them as in a quantitative way. And then this is how we get this equation altogether explain about 68% of the warfarin dosage variation among our 80 patients required. And then we use another 20 extra patients to try to validate this dosing models. So we know the other 20 patients stable dose, and we try to use their genotype, age, weight, and the vitamin K intake and predict what is the dosage requirement. And we're able to, and the ideal prediction is that the dosing variation is less than plus or minus 20%. That will be considered as the ideal prediction, and we're able to achieve that in 50% of the test case. It doesn't sound too high, and I have to say that it is not too high, but compared to the dosing algorithm published by the International Warfarin Pharmacogenomic Consortium in New England Journal of Medicine, which include many patients from different ethnic groups, and their effect size is about only 47%, so less than 50% of the effect size. And they also have a hard time to making a perfect prediction on people on applying the dosing algorithm. So after my experience of working on this model to try to make a nice equation that can predict what do we need, at least my take-home message that simply using a genotype guided dosing algorithm is not adequate to give us what we need. On top of that, we have to do something extra. And we're going to see what kind of extra thing we can help to use, boost up the TTR of the patient. Going back a little bit back in time, because I'm doing a lot of things simultaneously, back in 2003, we tried to get attention of our public health care provider about the need for an anticoagulation clinic. So it's a little bit unfortunate that in Hong Kong, our practice is about some year behind what we have here. Here, even at the time I was graduating in 1994, anticoagulation clinic is like very popular and later on considered as the standard of care for warfarin. But when I go back in Hong Kong in 1999, early 2000, majority, like 99.9% of the patients' warfarin care are still taken care by the primary care physician. And the warfarin clinic is like an experimental kind of service at that time and totally run by physician. So it's kind of time consuming for them. So the number of the patients that they can take in is very small. So we try to find some data to prove that the anticoagulation clinic work better, kind of repeat what Americans have done already. So we compared retrospective data on routine medical care and the AC clinic and find that the time within the INR is much higher. Well, I cannot say much higher, significantly higher in the AC clinic, even by different age group. Well, apparently only the only the patient with more problem will refer to the anticoagulation clinic. So we can see that the background risk factor of those patients that is assigned to the AC clinic is already not in the best shape compared to those in the routine medical care. But still, in the AC clinic, they are able to achieve a better target INR range time that shows this is working anywhere in the world, not just in the North American. It will also work in Hong Kong. And we also calculated the cost of the patient per year, including the emergency room visit, hospitalization, the test, and the visit, and show that the AC clinic end up overall have a lower overall cost per patient per year. If they were taken care by the AC clinic, that will lower the other costs that could be related to warfarin related complication. So that was the actual data we collect, and then we use some of the data plus other literature data to build a decision analytical model using the Markov method over a 10-year period of time. Now, at that time, my modeling is quite rough. It simply comes from two arms, anticoagulation clinic or just routine medical care, and without even considering how good they are doing the anticoagulation control in terms of INR, we jump right into, does it have an event? What is the event rate? And the event, is it major bleeding or major thromboembolic event? And do they die? Do they survive? If they don't die, do they continue the treatment? If they continue the treatment, how likely they're going to have a second event? Then we do this about for 10 cycles, for 10 years. And if I know that the marginal cost for the RMC, that is routine medical case, is more costly than AC, mainly because they have higher event rate. So all the costs is mainly come from the management cost of the warfarin-related complication. And at that time, I did not do any quality-adjusted life year gain measurement, which I did include that in my later model. But back in early 2000, the event rate per 100 years seems to be a more understood terminology for majority of the clinician and for publication purpose. So that one seems to be able to push through. So we show that the AC group is more cost saving with a lower event rate per patient year. And together with other help and all those work we done previously, we were able to obtain a grant and from Hong Kong government to start the first pharmacist managed warfarin clinic in a teaching hospital of my university. And of course, I have to thank, it's a quick thanks to the clinician who was running the anticoagulation clinic at that time, that they welcome pharmacists to get to the clinic and take up some of their patients. And basically, we say that we're doing a randomized, prospective randomized clinical trial to compare physician managed patient and pharmacist managed patient. And they know that we intend to show that we're doing better than them. So then I own them big time to allowing us to get to the clinic to do so, because they know our hypothesis is that pharmacists will do better. And so they must, in their heart, truly want to download some of the work. So in terms of support it. And also the physician in charge, Professor Gregory Chen, he was trained in North America. So he's used to the idea of having clinical pharmacist services in the team. So he's very welcome to let us in. I mean, without the help, we are no ways that we are able to show what I'm showing to you today. So we recruit 140-something patients who are newly started on warfarin at that time, which is also another difficulty because the clinic is kind of saturated already. At that time, we only able to take care of 300 patients in total in terms of the clinic capacity. So have to recruit another 100-something new patient is hard for us to do in the 2-year period of time. So after we, I think after the last patient was recruited, I think we at most can only follow that patient for 3 months before the end of our grant, before we spend all our money. So some patients that were recruited early on, we're able to follow them longer time. So at the end, we have to do everything in terms of the UN rate in 100 patient year. So all the unit is almost like in 100 patient year in order to make sense. So from our result, we show that this is we do have patients that in the high intensity as well as low intensity for different indication. Age-wise, I think they are slightly younger, so no significant difference in the both groups. So that will be something important to notice. So none of the group take older patient. So this is how it looks like in terms of the INR, the time of patient distribution in different INR range. The darker bar is the pharmacist managed group, and the slightly lighter bar is the physician managed group. So, and the top one is the IN for the low intensity, and the bottom one is for the high intensity. So you can see that the pharmacist managed group doing quite well. That always keep the patient within this 2 to 2.4 range, better than the physician group, and we're able to keep our patient within the 2.5 to 3.4 range in more in the high intensity group. Now overall, the time in therapeutic range, we were slightly doing better for 2 to 3, patient indicated to 2 to 3, and the 2.5 to 3.5. And overall, while we're doing good. So 60-something% patient time in the therapeutic range is the best that we can achieve. And in an anticoagulation clinic run by pharmacists at that point back in 2005. And if you're familiar with the warfarin control, you can see this around 60% is kind of the average performance of most of the anticoagulation clinic in terms of how good they keep their patient time in the therapeutic range. And we also compare the cost item between the two groups in terms of the outpatient clinic visit, emergency room visit, and hospitalization and medication, and overall cost that we are causing lower. The lower cost mainly come from the clinic visit because as a matter of fact, pharmacist salary costs less than the physician. Even though the pharmacist spend a longer period of time with the patient, that still add up to be costing less than the physician run the clinic visit. So that seems to give us the advantage of able to be cost saving because pharmacists get paid less. And we also do a patient satisfactory survey questionnaire, and show that the pharmacist managed group score slightly higher than the physician in majority of the items, including general satisfaction, the technical quality, interpersonal manner, and communication, and time spent, and as well as accessibility. I think the keyword that make everything about the patient satisfaction is the time spent. Pharmacists able to spend more time with the patient in terms of the education and listen to their problem. So that will also, and we also provide a hotline for the patient to call in if they have any questions, because it will be impossible in Hong Kong that you can find the doctor directly on the phone. So we are providing a hotline for patient to call a pharmacist, make a very big difference to how the patient feel, how they satisfied they become. Now, next we want to show you, this is what so far the experience is that we tried the traditional way of anticoagulation services with suppose the best type of personnel to do a pharmacist, and still the time in therapeutic range is difficult to strike higher than 70%, 60%, some 65, 64% is like the plateau in most of the scenarios. So that is how I've putting my mind on how to strike it higher, or is there another way to use anticoagulation therapy in a more cost-effective way? So that comes along with the warfarin pharmacogenetics. Now, back in 2004, I build a simulation model on hypothetically using pharmacogenetic guided management of warfarin therapy, and it's a decision analysis is over 1 year of time. And the concept is that knowing versus not knowing the genotype of the patient should make a difference. And how does this difference make? At that time, I have no idea. Okay, but I truly believe that knowing somebody is at risk, that they require lower dose, you can do something about it, and in a way improve their outcome by reducing the risk of bleeding or risk of ischemic event. So my idea is that for the control group will be just standard AC care, and versus a genotyped group that you know the genotype, and at least one of those carrying a high-risk gene. And that was 2003. At that time, we don't even know about CPR, the we call C1 yet. So it's all about CYP2, C9 at that time. So they should put, and my concept is that those patients who are known to have carried some polymorphism for low dose requirement, they should put in a intensified anticoagulation surface. How is this surface run? I don't have any detail at that time. And then if they were know that they're wild type, they can go back to just a regular standard anticoagulation care. And that's the point I have to make some assumption. How good is this intensified anticoagulation surface compared to standard care would able to work? At that time, I make an assumption that it will reduce event rate by 20%, which was, and now I think about it, it's like a crazy assumption. It's way too big than anyone can show 10 years later. Okay, but at that time, there was some paper putting out there about intensified anticoagulation surface with more intensified education and more frequent monitoring than the standard anticoagulation care. They are able to reduce around 20-something% of the event rate. I was being conservative at that time when I only picked 20% reduction. But then at the same time, think about if you're doing intensified surface, you have to put in extra resources. So at the same end, I put down incremental factor on the cost of this service. So this service cannot cost the same as the standard care. It has to be cost more in order to provide better service. You cannot ask people to work longer hour or see the patient more frequent for free, right? You have to add in. So I put down 50% resources. I'm just like doing like a monopoly on my own. I'm just going to add in more money into this service, bet on more money on this service, about 50% more. And it showed that even in that case, the genotype cases will, the genotype group will be approximately $5,000 more per 100 patient year, and then preventing about 0.9 cases per 100 patient year. So this is leaves somebody else to decide whether they want to pay up this extra money to reduce additional event rate. Now, interesting enough, just a little bit down the road, that the previous model I built was 2003, and this one is 2007. This is the first randomized clinical trial of using genotype-guided dosing regimen to compare with what they call the standard dosing method done by the Anderson group. This is the Coumadin study. At that time, it's very disappointing because the so-called marker on out of range, IN out, in the standard group was very low, only around 33%. That, in another word, that means almost 67% of the cases are within range. So they have a very high quality on the anticoagulation control in the standard group. And the PG group, even with the additional help of knowing the genotype and then tailor making the dose for the patient, it can only reduce absolute change of the reduction by only 2.4%. And it's not even significant difference. So absolute change is only 7%. So the discussion is about it. They pick someone too strong to compare with. If they pick a low, a more poorly managed group to compare, they might show a better improvement. But they pick on a group of clinic, they're already running their clinic really well. That's why I keep saying that 60-something% is already a very high performance in terms of anticoagulation management. So it's hard to break out this plateau, so that this one is already 69%, close up to almost 70% of in control range. Now, knowing that this is not very suggestive, I mean that the genotype, the Coumadin study was not very supportive of the genotype-guided dosing. So at that point, I feel like that the model need to be updated with those new information, including about the new finding of the VCOS-C1 as well as the coumagene's findings. So we built a new model that was published in the Clinical Pharmacology and Therapeutic in 2009. And I think it was accepted in 2008. So it's like shortly after the Coumadin study. And this time I make the model a little bit more polished, including try to use the surrogate of INR, how patients perform with different dosing approach or management approach that can change the INR management, and from the change of INR management project on the change of the complication rate, including bleeding, TE, or no event, and also further differentiated the nature of the event. Is it an ICH or ECH? Does the patient survive in death? So the model become more polished this time. And this is still just a 1-year decision tree model. I don't want to project too far off without certain about the input can be challenged. And at that time, I used the base case value from the Coumadin data. That is the standard, the control group on how good they controlled the patient out of range. So only 33% of patients out of range, and using genotype guiding to dose the patient only give a relative reduction of 7.3%. And of course, the result showed that the ICER of the genotype guided group and everything is converted to quality adjusted labia gain, even in a 1-year time point. It's not cost effective. It's way higher than $50,000 per quality. That is considered to be an acceptable threshold. But then that is not the point to get. Well, I think we already get the idea that it wouldn't be so strongly cost effective. But at that time, my focus is how to make it become cost effective. So the sensitivity analysis becomes the key of this study. I tried different variable and put them in different combination and see how can we make the genotype guided method become more cost effective. So we find out 3 model input seems to be the most influential. And number 1, the cost of genotyping. I think at that time I put in 200 is my base case cost of genotyping, and I tried lower cost 50, and then high cost 350, and even 550. And the darker colors show that the combination of the other 2 variables will find the ICER of genotype group become cost effective. That means less than 50,000 to become acceptable. So the other 2 critical variable is the baseline out of range IGNR. So how good is this group are already performing before you add into the genotype guided method. And the other one will be the relative change, and I assume reduction. I hope that if you add genotype, it won't relatively increase the out of range INR. So the relative reduction of out of range INR together with your baseline out of range INR are 2 critical variables that affect how likely this method will work. So if you have a very well managed group, it's probably it's more worthy just to stay what you're doing without putting resources to add on the genotype, because it's very hard to make it more cost effective than what you already done. But if you start off with somebody who is very poorly managed, maybe only get 40%, maybe get 60%, 50% of the time out of INR, then those are the group that you should tackle at. And you only need to have not too high if you are even using 200 as your benchmarking cost of genotype, and you have somebody that have half of the time in the range and half the time out of range, you don't really have to reduce too much relatively. You have to reduce it, the INR by maybe 30% or even less to get you into the accepted zone for the ICER. So this is the concept about what are the modifying variable in your care model that you can work on to make this become cost effective and acceptable. And then around about the same, just maybe a year or 2 later, I do a review article and look at how people were doing doing different type of cost effective analysis of applying pharmacogenomics for warfarin therapy. This red line representing the timeline of the Coumadin study. before the Comogene study was published, everybody was so optimistic that the genotype can be cost-saving and reducing the event rate, or just with a very small amount of cost increment, then you can reduce event rate. But after the Comogene study was published, all the study have to use the Comogene data and then find that the ICR of the warfarin genotyping not that cost effective, and there's actually many more coming later on, but then we have other new data to work on, a new drug working on to make the comparison. Now this is like one of the new change. I think the WeLi published in 2009 or 2007. That is the first NORWAC that come onto the market. That is the Bicodrin. And that time, so many people come out to do decision analysis to compare the Bicodrin with warfarin managed in usual care. And I make a comparison between the Bicodrin with genotype-guided management of warfarin. So my concept is that you cannot just simply use the dosing method alone and then put the patient back into your regular anticoagulation care. If you know somebody is at risk with a suspiria of CYP2C9 free, star 3 or star 2, you have to do something more than simply giving them a dosing algorithm. So they should be put on a more focused group care. So this is the model. It's a Markov model for lifetime now. So by expanding the previous model I published in CP&T, this time this is a lifelong model with yearly basis, also incorporated the INR control as the surrogate to bridge between different dosing method or different anticoagulation therapy to the outcome. The thing to notice that I use the average performance. This is the usual AC care. This 64% of time in therapeutic range come from the WeLi study, because they have like thousands of patients and half of them put on warfarin, and that is how average they are being in control is about 64%. And now this 78.9% of time in therapeutic range in the AC group is borrowed from the idea that a study published by Epstein, I believe he's in Johns Hopkins, it's one of those big hospitals, that what they did is that they provide the physician with, in 2009, they provide physician with the genotype of the patient when they start the warfarin therapy, and with some interpretation of what that means. And the physician, knowing that the genotype of the patient and the interpretation of those genotypes, they manage the dose differently and they follow up the patient differently. And the overall readmission, hospitalization rate and readmission rate over the time is decreased. So I use that to simulate what would be the, well, I kind of back calculate what would be the time in range will require to achieve that kind of reduction. So still keep using the INR as the key surrogate variable that I can use in the model. And then make a big range between the standard, and then have to test it over a range between the usual care performance and very unrealistic 100% time in therapeutic range. But we can see like how high you really need to make it work. And then another interesting input that turned out to be a inferential factor later on in the sensitivity analysis is the utility value of warfarin therapy and the Bicodrin therapy. Initially, I select some value from literature that they were not that far away from each other. But I have to say, the reviewer of the journal kind of like strongly recommend that the Bicodrin should be like as good as 1, because the patient do not need frequent blood draw and they can eat whatever they eat, so their utility should not be affected at all. So you should use 1 in that case. And warfarin should be like the lower end of the range because they have to do frequent blood draws. And I see some other authors see things in the opposite way. They would say that the Bicodrin can cause dyspepsia and that can cause patients more discomfort. But because this journal I published in this particular timing and with this particular group of reviewers, they believe that the warfarin utility is supposed to be lower than the Bicodrin. So that's why the number was chosen there, but they turned out to be inferential factor, because just any slightly closer gap, closing the gap between this two agents already affected the effectiveness of these two. Now I compare 4-arm, the AC arm guided by genotype usual AC arm and the 2 dosage level of dabigatran, and you can see that the dabigatran 150 is the most cost-effective one with the highest quality gain and also lower cost, a higher cost than the genotype group, but with the acceptable ICR achieved. And these are two-way sensitivity analysis comparing those three factors that I identify. One is the utility of warfarin, the other one is utility of the dabigatran, and also the time in therapeutic range of the genotype-guided AC. That shows you that if the dabigatran utility coming down a little bit, and the even if they're the same, the use of genotype-guided AC will more lean to preferring the AC-guided warfarin. And on this chart, you show that if the warfarin utility is not as low as 0.95, but maybe somewhere in the middle in between, then you don't need to have that high of the time in therapeutic range to achieve the cost effectiveness for the genotype-guided AC as the preferred one. So there's a lot of interaction going on that really, I think that's deserve to really looking into the utility of the two agents, because all this threshold is based on the cost per quality gain, and quality is highly depends on the utility value of a particular therapy. So if this is a slightly difference between these two, because most of the time patients do not have an event, they're just taking the drug. If there are actual differences between the utility between these two, that could make a difference. So I think somebody should really go out to measure the utility of the people actually taking the drug. Because a lot of time we are based on some very old literature, because the utility of dabigatran is based on the quality of light change in the prototype of NOVAC, which is already been like not even going out on the market because of the liver toxicity that long time ago. And this is an acceptability curve. So the dabigatran 115 marginally doing well, slightly higher than 50% of chance to be cost effective compared to the genotype guided AC. So it is not like a way ahead of win. It's a kind of close win. Now, all this data, all this work I did put me in the thought that we need, if we want to use warfarin over NOVAC in a cost-effective way, you have to really achieve a high time in therapeutic range. That means the level of anticoagulation control really need to be break through the plateau 60%. Okay, and that may also come with additional cost. So that's why this is a study I usually, at the beginning, the title is like a business case. But then when I put a business case, nobody accepted it. So I have to go back to a cost effectiveness analysis. So I look in, just simply looking at NOVAC and warfarin, and then warfarin, they in 3 different scenarios that is controlled with TTR at 60%, 70%, and 75%. And looking at, and this time I'm able to, from relevant reference, put down warfarin and the NOVAC utility in a more similar range, not that like a 0.5, 0.05 different, that will be quite big a difference. Right now, the NOVAC is supposed to be just slightly feeling better for a patient than a warfarin. Okay, and the base case result actually it's more like a scenario analysis. So a few scenario has been mapped out. So 3 different level of time in therapeutic range achieved by the warfarin group at different costs. So there will be no additional cost, neither 1.5 times higher than your usual cost as a routine care, 2 times higher than the care of the usual warfarin cost, and then this is how we map out. We can see that when the time in therapeutic range was low, 60%, of course, additional costs will even make it worse. The ICR of the NOVAC will be all below the acceptable range. So they are all preferred scenario for the NOVAC that is in the bolded color of the ICR. But if the people able to achieve TTR for 70% in the warfarin group with no additional cost to your usual routine care, I mean the warfarin clinic care, then NOVAC will be considered as not cost effective, because the margin of cost difference the margin of the quality difference will be more narrow in that sense, so that will make the ICL higher. And if the cost can go as high as 1.5 for the AC group, and still the NOAC will be still considered as not cost effective at this point, which is more prominent in if you're able to increase the effectiveness of warfarin with no additional cost or very high additional cost, then you can seem to allow a leeway of putting additional resources if you can deliver 75% of TTR in the warfarin group instead of using NOAC. So these are the scenarios that I intend for the budget holder to consider. So if you have extra money, you can just directly buy the NOAC. Or if you believe that you can put in some extra money, smaller amount of extra money, but improve the TTR of your current service, then you may be able to do better than entirely switching to NOAC. So this is a business case to me, even though it's called cost-effective analysis. And this is the two-way sensitivity analysis and the acceptability curve of the 3 different TTR levels that possibly can be achieved with different tricks. And also the 2 variables put on the 3-way sensitivity analysis are the additional cost, like how many times higher of a monthly AC cost, and the monthly cost and NOAC, because the NOACs can adjust their price as well. If the NOAC's price come down, then the NOACs are more likely to become the cost-effective agent because they already have the effectiveness. All they don't have is not affordable cost. So if they're willing to come down the price, then it's hard to make the warfarin become more cost-effective than them. And I'm down to my last 2 paper. Well,
So we have 5 more minutes.
good. Okay. This is like a crazy idea, okay? Instead of using pharmacogenetic of warfarin to dose the patient or to manage a patient, now I decided maybe we can try thinking about use warfarin pharmacogenomic to rule out patients for using warfarin. So if we have such a good drug out there, expensive drug, NOAC, and some people are known to be very difficult to control with the CYP2, C9, star 2 or star 3. They're so difficult to control, easily tip off. Why don't we use that to rule them out? Just give them NOAC so you don't have to worry about them once and for all. So this is an idea to use the pharmacogenetics of warfarin to guide the use of either give them NOAC or warfarin. So if they're warfarin sensitive, they should put on NOAC. If they're having the wild type, then they can put on warfarin dosing. Of course, since you already know the genotype, why not use the genotype to dose them as well, and plus give them a proper care. So in that sense, now this 71% is come from the Coumadin 2. Coumadin 2 already published by then. So this is how Coumadin 2 show that they actually can do better if they keep repeating, adding the follow-up INR into the equation. Then they can improve the TTR much better. So some of the factors that shows to be inferential are circled red here, and it showed that the PG guided selection of anticoagulation clinic is more costly but more effective with an ICL only of 2,000 something, less than 3,000. So it's considered to be highly cost effective because it's way below 50,000. And these are some of the factors affecting it. So if there are less people having, well, actually the whole sensitivity analysis always showed that the PGAC is going to be better than the usual anticoagulation clinic, but the variable only change it a way that it will become cost saving and effective. Right now is additional cost and more effective. Shifting some of the variable below will make it cost saving and effective. So it's highly, the possibility to become cost effective is very high. My last paper. So since we already did that with the usual AC, why don't we try with, like, if we either have everyone put on the NOAC or use the same approach to select them. And this 81% of how an warfarin clinic achieve is come from Dr. Henry Bussey's paper on how to remotely monitor patients who are on self-testing. So I can just find paper to show actually it can be done. 81% of time in therapeutic out can be done. Okay, but definitely it might have come in additional cost. Now in this time it showed that the universal use of NOAC is more effective, but come in additional cost of this much, 300 something thousand. So it's not preferred option. So the PG arm will be the option. And this is a scatter plot to show the additional cost and additional quality gained by the universal use of Norway. That means you can see this is the dotted line is the threshold of willingness to pay. Majority of the go above this dotted line. That means majority of the case are considered not cost effective. And well, we also have some randomized clinical trials. Some show chromogen to find that the genotype method is effective. COAG done in US not that appealing, but then EU PAT, majority of the Caucasian in European country find it very effective. So depends on the patient selection group. I guess that means something too. So what's next? Last two slides. Important to find the balance between the new and old anticoagulation clinic. Now, in Norway, the long-term use seems to show higher bleeding rate right now, and so there's uncertainty of long-term safety. And no monitoring not necessarily means it's safer. It could mean some false sense of security for the clinician, and plus the high cost is something that we consider. And warfarin, the most affordable one, as cheap as water, but then patient will be at the highest risk when they started the therapy in the hospital, and in long run, a high TTR is required to make it cost effective in any way compared to the universal use of Norway. So with the availability of Norway right now, I think the message is that you must add additional resources either way. You either pay money to give Norway, or you pay money to improve the warfarin quality control in terms of the anticoagulation care. The personalized medicine approach, there are many ways that we can use the genotype. Using it for dosing alone, I don't think that is adequate. I think many of us here, we think that seeing all we're seeing right now, sometimes it works, sometimes it doesn't work, even in clinical trial, and it's not adequate if we simply use one formula. How about dosing with genotype has some focused care? So once you know a patient is at high risk by the genes, you dose them with a special equation and follow them up with some more focused care that can possibly be adequate to increase the TTR. And what about selecting them, the high-risk patient, just out of the warfarin pool that work on paper, at least in the virtual way? And also, the genotype-guided management in the initial phase is critical up to the 90-day. Some work has been done in the UIC. Edith done some work here to show that they have a inpatient warfarin pharmacogenetic dosing service to find that they're able to reduce the readmission rate and complication within the first 90 days and when the patient start treatment. So, and we work together to do a decision analytical model, and our preliminary findings show that this service can be cost saving with improved quality, just a life year. So I think there's many more work to be done. Thank you for your time, and now time for questions.